feel like there's a section of material that you want to go through, or do you want to just go from start to finish?
Um, I guess just from start to wherever we till you have to go, and then
Okay.
I could pick up on the other professor's review. You know what I
Okay.
mean?
Yep, that's fine.
Okay.
That makes the most sense to me.
Okay.
Okay. So it's going to be chapters 25 through chapters 32. So 7 chapters.
Okay.
Week 6 through week 8. Your study guides will help guide you. Okay.
Okay.
And then utilize Kahoots as well.
Yeah.
Okay, so
Okay.
respiratory review. So atelectasis is the collapse of the alveoli in the lungs. Okay.
Right.
You can read all of this stuff. Surfactant, so that doesn't start being produced until 24 weeks of gestation. And that prevents those alveoli from collapsing. So that helps expand the alveoli starting at 24 weeks gestation. Now, babies, if they're born early, they'll still usually get a surfactant injection up until like 35, 36 weeks.
Okay.
Kind of an extra little dose for them. Tachypnea, obviously, that's elevated respiratory rate. Ventilation is the process of breathing air into and out of the lungs. So your erythrocytes or your red blood cells, that's what carries oxygen to the tissues and carbon dioxide to the lungs. And that exchange is what's happening with the erythrocytes help. Okay. Your signs
And
of
children should have a over 90 or above, right?
yes, for an oxygenation. Yes. Yeah. For your saturation. But remember what affects that. If they're flailing about, crying, screaming, you're not going to get a real accurate read.
Okay.
Also, if they're really cold, or they have a cardiac defect and you have it on their finger and they don't have good peripheral perfusion, then that's going to affect that number as well.
Oh, okay. Makes sense.
Signs of respiratory distress, make sure you know those. So that way, if you're reading questions, and they're throwing some of those signs in there, that can kind of clue you into that they're having respiratory distress.
Okay.
So pharyngitis, we put this under respiratory illness. Most common is strep pharyngitis. So group A beta hemolytic strep needs an antibiotic because if it's not treated, then you can have any of these potential risk factors of not treating it. The glomerular nephritis, remember, that's from not completing our antibiotic as prescribed for the full 10 days.
Okay.
Okay.
Yeah.
Pharyngitis can also be viral driven. So if kids test negative for strep, then it's probably a virus, and just supportive cares for that form of strep.
Okay.
So like saltwater gargles, Tylenol, ibuprofen, things like that. Okay.
Okay.
A URI or respiratory tract infection. So that's an infection of the upper respiratory. So it could be nasal passages, nose, throat, ears. Cough can go along with that.
Okay.
Fever wise, if they have a fever, you want to make sure that they're drinking plenty, because kids, if they have fever, they're already at increased risk for dehydration purely because they have that fever. Okay.
Yep.
Same with sore throat. Like, you want to make sure that those kids are getting something for pain, so that way they keep drinking.
Okay. Makes sense. Yeah, because they're not going to want to swallow if they're hurting. So pain.
Right.
Okay.
Right. Bronchiolitis, so that's the inflammation of the small airways, so the bronchioles within the lungs. Okay. So small airways. You don't see bronchitis as much in kids as you do in adults. Okay.
Okay.
Bronchitis is bronchi, so that's the bigger airways in the lungs, whereas bronchiolitis is the small airways within the lungs. Typically viral illnesses, most commonly RSV is what causes bronchiolitis. Okay.
Okay, and 6 months to 2 years.
is your most risk.
Okay.
Yep. But doesn't mean that they can't get RSV at 2 weeks, because last week I had a baby who had RSV at 2 weeks.
Oh man. Okay.
Yeah, they went to the hospital.
Wow.
So it doesn't mean that it starts at 6 months. It can definitely
Oh.
start beforehand. Okay. But
Hmm.
that's the most common kind of age range.
Okay.
Usually every kiddo's had RSV at least once before age 2.
Oh, okay.
Can cause viral pneumonia as well. Okay.
Hmm.
Asthma, so that's a chronic respiratory illness that affects kids. It can also go into adulthood. The most common reason why kids miss school, okay, the leading cause of ER visits because their asthma is not managed appropriately, and then they wind up being hospitalized.
Okay.
Remember, with asthma, we're treating with inhalers. Okay.
Albuterol is the rescue inhaler.
Yep.
Okay.
Yep. Albuterol's the rescue. So if it's just a mild form, with exercise or something like that, or with allergy seasons, then they'll utilize the rescue inhalers. But if it's something, that the rescue inhaler, they're still waking up in the night, cough, cough, coughing, often a long-term, like a long-acting beta agonist is added, like so with a corticosteroid.
Okay. Okay.
And then that would be an inhaler that they're using, once or twice a day.
Got it.
Laryngotracheobronchitis, remember the other name for that is croup.
Group. Yeah.
So they'll have that stridorous, that noise.
Yeah.
Okay.
Okay.
Epiglottitis is inflammation or swelling of the epiglottis. Okay, so that's a tissue over the vocal cord, most commonly caused by Haemophilus influenza, which we have a vaccine for, HIB. That's that vaccine.
Okay.
The HIB vaccine, B as in boy. Okay.
Yes.
But epiglottitis is a life-threatening emergency. So if parents notice kids drooling tons, not swallowing their secretions appropriately, tripoding, so they're leaning forward, trying to get air in.
And that does the venous return. Is that why
what
they lean forward?
what was that? I'm sorry.
I'm sorry, I might be thinking of a different class. When they lean forward, it helps with the venous return of blood. Is that?
No, I think you're thinking of tetralogy of Fallot when they
Oh,
squat
yeah, yeah,
down.
yes. I'm sorry.
Yep.
Okay.
Nope, that's fine. So
Okay.
essentially what's happening is they're trying to get in a position where they can satisfy their air hunger. So where they can
Oh,
feel like they can get more air in. But because of the epiglottis being so swollen, they're not going to be able to get air in. So these kids will need intubation and potentially trach placement
okay.
if they can't be intubated right away. Okay. And they'll be
Yeah.
given steroids. With croup, also steroids are usually used, but sometimes kids have to have inhaled epinephrine, so racemic epi, so nebulized epi. So if kids get that, they have to stay in the ER for a little bit, like a
Okay.
couple of hours to be monitored. Okay.
Okay.
Cystic fibrosis. So it's in respiratory illnesses, but remember, it's systemic. It affects multiple body systems. Okay.
Hmm.
It affects our GI system because we're not absorbing our nutrition appropriately. If we have cystic fibrosis, we have really thick secretions that obstructs airways, but it also causes thickened mucus in our respiratory areas. Okay.
Hmm.
Diet wise, they have to have high protein and high sodium because of what they're losing in their nutrition. They will be on pancreatic enzymes when they eat, so they can hopefully more fully absorb those nutrients. Okay.
Okay.
They're going to lose their electrolytes through sweat, specifically sodium. So like this sounds really gross, but if you licked a kid with cystic fibrosis, they would have very, very, very salty tasting skin.
Okay.
Okay, so they sweat out their electrolytes. They're going to have bulky, foul smelling, frothy stools because they're not absorbing all of that nutrients, just kind of flushing through.
Okay.
And males will be infertile with cystic fibrosis until at least a year after they've had a double lung transplant. Females can have some infertility as well, but they're not sterile like the males are.
Okay.
Okay, that was the end of respiratory review. Any questions?
Let's see. So you said the pharyngitis is mostly caused by strep A, but it would need it, if positive for strep, it would need the antibiotic, but if it isn't, then it's a viral.
Yeah,
So
most
like
likely.
worse.
Yep, a viral or another strep bacteria that we don't worry about treating with an antibiotic.
Okay. Okay.
Yep. So there's like A, C, G for strep.
Okay.
And the only one we worry about treating with an antibiotic because it has that risk factor for rheumatic fever, right, is group A strep.
Okay.
Okay.
Yep.
Okay. Cardiac review. So chapter 26. So the heart is the first body system in utero that's functioning. Okay. So a lot of things can happen in those first few weeks in utero. Like moms don't know that they're pregnant, so maybe they're still using substances, that are risky, that can cause cardiac development, or maybe they're not on a prenatal because they didn't plan on getting pregnant. So there's a lot of things that can go wrong.
Okay.
Tachy is fast. Okay.
Mm-hmm.
So tachycardia is fast heart rate. Brady is slow. Dyscardia is ill or bad, so abnormal.
Okay.
Like a dysrhythmia, right? Okay. Hypoplastic means abnormally small or underdeveloped. Okay.
Okay.
All these terms will kind of help you to think about the different defects. A shunt is the pattern of blood flow that's different from normal. So typically the pressure is higher on which side of the heart?
The left.
Yes.
Yes. Okay.
Yes. So shunting wise is going to go from high pressure and it's going to try to go to low pressure.
Okay.
Okay. Murmur, this is a sound of blood flow that's abnormal. So when you listen, you can hear a murmur, so like a swishing sound or a mechanical kind of clicking sound, or you hear an extra beat. So instead of just lub dub, you hear an extra kind of beat in there.
Okay.
Some murmurs are innocent murmurs, so that means that there's no defect or any issue that goes along with it. That kiddo just has a murmur. Sometimes that happens if they're low on iron, or if they're sick. You can notice it more often, but nothing to do about that.
Okay.
If it's an innocent murmur. Obviously, if it has a cardiac defect with it, then it needs intervention. Okay, cyanosis is the bluish or purple discoloration that suggests low oxygenation. So you might notice cyanosis around the lips, cyanosis of the hands or the feet, right, at the nail beds.
Mm-hmm.
Okay, so that's all suggestive of that kiddo having a cyanotic defect. Okay.
Mm-hmm.
Acyanotic means that they're normal or very normal oxygenation. Okay.
Okay.
And stroke volume is the amount of blood that's pumped out of the heart with each contraction of the heart.
Got
Okay.
that. Mm-hmm.
Okay. Okay. So ASD, sorry, it's kind of hard to read that dark gray, isn't it? So ASD, so this is an opening of the septum of the atria. So the septum, remember, that's that middle wall. of the heart, and there's an opening between the two sides. So the pressure is higher on the left side. We already decided that. So the shunting is going to go from the left atria to the right atria. Okay.
Yep.
Just going to increase the blood flow to the lungs. So does that mean that this is a cyanotic lesion or an acyanotic lesion?
I would think acyanotic.
That's right, because it's circulating to the lungs multiple times, right?
Okay.
So surgery or cardiac catheterization, they go in and they close it with cardiac cath through like the femoral arteries. Okay. So that opening needs to be closed. Okay.
Okay. And is there an age that usually happens, or was that nothing?
Not necessarily. It's more based on the significance of the opening.
Okay.
So if it's a pretty small opening, they may even, and the kid's not having a lot of issues from it, they might even leave it be.
Okay.
So they might just have like serial echocardiograms with cardiology to keep an eye on it to make sure it's not getting bigger. Okay. So a VSD, same thing as an ASD, but between the ventricles. Okay. So still the blood's going to shunt from the left side to the right side, and the right ventricle then is going to pump it to the lungs.
Okay.
So once again, increase blood flow to the lungs.
Okay.
So
acyanotic.
Acyanotic. Yep. Surgery is more likely with VSD versus ASD. Because ASD, I feel like they'll do cardiac cath closures more often. Not that they can't do that with VSD, it just seems that it's a little bit more tough to do that as a cardiac cath. Okay. So they're going to have cardiac cath to repair it or surgery, but mostly surgery with VSD.
Okay.
Yeah. Okay. PDA. This is what babies have for their circulation while they're in mom's bellies. They have to have this opening, and right here's your PDA. So essentially, this is kind of a way to bypass circulating, all to the periphery.
Okay.
Does that make sense?
Yeah.
So it kind of helps recirculate it back to the lungs. Okay. Should close on its own within a few hours after birth. If it doesn't, then they'll give indomethacin, which is an anti-inflammatory medication. If the indomethacin does not work to close that PDA, then they'll have surgery or cath closure. Okay. So because there's still blood circulation to the lungs, it's an acyanotic.
Acyanotic. Okay.
Yes. Okay. These kids can potentially have more blood pressure issues. So just keeping an eye on that. Okay.
Is that even after surgery?
So after surgery, yes, it's less likely to be problematic, but it still is something that can happen.
Okay.
Okay. Coarctation of the aorta. So a coarctation is essentially a narrowing, or restriction of blood flow. So you can see that in this picture right here. Here's your aorta, and it goes from being this big vessel to having a tiny opening for that blood to go through. So with that tiny opening, what's going to happen? That blood's going to back up, right?
Backflow, yeah.
It's going to backflow into the left ventricle. Okay. So the thing with coarctation of aorta, you're going to notice the upper extremity blood pressure is going to be higher than the lower extremities blood pressures.
Oh, yes, I remember that. Yeah. Okay.
Okay.
Yeah.
So to rule out a coarctation, you could do blood pressures, one on each extremity. Okay.
Okay. Yep.
And then if the blood pressure is significantly higher in the upper extremities, then that's suggestive of coarctation. Okay.
Got it. Yep.
If this isn't corrected, these kids will progress to congenital or congestive heart failure. Okay.
Okay.
They treat this with surgery. Sometimes they'll go in a cardiac cath lab and go up through the aorta, and they'll insert a balloon to kind of balloon that narrowing or coarctation back open.
Okay.
Okay. If that's not successful, then they have to have surgery.
Okay.
Okay. So what do you think this one is?
Cyanotic.
Okay.
Wait a minute, left ventricle. So, well, uh, yeah, acyanotic.
Acyanotic.
Yeah, okay.
Yep. Because that blood is still getting circulated to the lungs.
Okay. Yeah.
Because it's going its normal path all the way through. It just, the amount that gets to the body is decreased because of that narrowing.
Makes sense.
Okay.
Yep.
Good. Okay. Tetralogy of flow. Like I said to you guys in class, exams, HESIs, NCLEX likes to ask about tetralogy of flow because there's so many defects in one condition. Okay.
Okay.
So they're going to have the VSD. So they're going to have the opening between the ventricles. Okay.
Mm-hmm.
They're going to have then pulmonary stenosis. So narrowing of this pulmonary valve. Okay. So then that's going to make it even harder for that blood to get to the lungs. Okay. Then they're going to have an aorta that the opening's kind of, down here between the two sides. So then you're going to have more shunting here too.
Okay.
Okay. Because of all this shunting, because of all the pressure that right ventricle has to try to pump through the pulmonary artery, and then, it can go easier through the aorta. Because of that, there's going to be thickened right ventricle. So right ventricular hypertrophy. Okay.
Okay.
On x-ray, it will look like a boot, their heart. Okay.
Okay.
This is your TET spells. So they're doing their thing, running around, and then all of a sudden their oxygenation drops, right? Because the demand on their heart's getting to be too much.
Yeah, because it's
The
pumping.
blood's not returning back like it should. So that's when they squat down to get that blood back to the heart like it needs to be.
Got it.
Knees to chest, or in an older kiddo, tell them to squat down.
Okay.
Surgery will be repaired. This will be repaired in multiple stages. They don't go in and do all the repairs at once.
Oh, okay.
Okay.
Yeah. Okay.
Age-wise, they'll start with most significant need for repair first. Usually they shoot to do that around 3 to 9 months of age, depending on the cardiologist. And then they do steps from there. Okay.
Okay.
Questions on tetralogy of flow?
No, I don't think so.
Okay.
I think I understood what you were saying. Okay.
Okay. Hypoplastic left heart syndrome. Now, I don't know that we got to talk about this very much during our lecture. So
Right.
this is a very underdeveloped, you can look right here at this picture. Look at how underdeveloped that left side of the heart is compared to the right side.
Yes.
So essentially, especially the left ventricle is underdeveloped. Their aorta is also underdeveloped. So look at how tiny their aorta is. Okay.
Yeah.
And then they keep that PDA as well. Okay.
Okay. Mm-hmm.
So blood doesn't want to go through that tiny little aorta opening, right?
Right.
So a lot of times there's a ASD. Okay. So there's shunting here. So there's some mixing of the blood, right? This is purple blood.
Mm-hmm.
Purple blood is essentially what's going to the body. But it's very, very, very low in oxygenation because the oxygenated blood can't circulate well because of that aorta being so tiny.
Okay.
Okay. 3 stages of surgery for this repair as well. Okay.
Okay.
Norwood or Santo. I've only ever heard it called the Norwood procedure, but that's probably just because the Pete's cardiac surgeon that I worked with, that was the preferred method that he chose.
Okay.
And then bidirectional Glenn and the Fontan. So after they have the Fontan, their heart should function more like a normal heart. Okay.
Okay.
However, these are your blue babies. They always look blue, even after repair.
Okay. Okay.
And a lot of times they don't live a super duper long time.
Okay.
Okay.
Okay, so the first one is the Norwood or the Santo. Then the second surgery is the bidirectional Glenn, and then the Fontan.
Yep.
Okay.
And the last one is the Fontan. Yep. And your book should have a quick description of each of those surgeries and what they fix with each one.
Okay.
Okay. But essentially the left side of the heart, hypoplastic, underdeveloped, right? Is what that's saying. So everything involved in the left side of the heart is underdeveloped.
Okay.
Including the aorta. It is tiny. And then you have that PDA. So then there's more shunting there, right? So it remixes before it goes to the body. Okay.
Yep.
And an ASD. If they didn't have that ASD, it would be pretty problematic for them too.
Yeah.
Okay.
Okay.
Okay. Your diagnostic tests, I'm not going to read those to you. You can read those. But obviously signs and symptoms of CHF in kiddos, sudden weight gain, tachycardia at rest, and difficulty breathing. Okay. Complications in kids with cardiac defects, obviously pneumonia is a concern because that's going to put more risk or need for demand of the heart. Rheumatic fever, right? So if we have strep and it's progressed to rheumatic fever, so our joints are involved, so cardiac involvement prior to.
And that's where they get the penicillin for 5 years.
At least 5 years. Yep. Yep.
Years. Okay.
Yep.
Okay.
Yep. And that's to prevent further heart damage.
Okay.
Okay. Meningitis can happen. So infection in the meninges, so the lining of the brain and the spinal column. Okay. And then glomerulonephritis, which is what happens when we don't finish our strep antibiotics and our kidneys, that glomerular tissue in the kidneys start becoming attacked as if it's a foreign kind of antibody. Kids with cardiac defects also, for some reason, have more ear infections. Otitis media. Okay.
Okay.
Okay. Early signs in infants. So sudden weight gain, sweating, fatigue during feeds, sweating during feeds, not growing appropriately, tachycardia at rest, difficulty breathing, frequent respiratory infections too. I would put that in that category. Nursing care. So organize, always, cluster care if you can. Do as many cares in one setting with kids, but especially with kids with cardiac stuff because they're going to be hospitalized frequently. So try to organize your care so you're not disturbing them so often, so they're not getting that to where they're crying, they're having more demand on their heart. Okay.
Okay.
Feed early before they're crying okay. So that way they're not crying and already wearing themselves out before parents start to feed them or before you start to feed them. If they're asleep, you can let them go a little later.
Okay.
They're going to have smaller amount, more frequent with CHF kids. Same with respiratory kids. A lot of times I tell parents, they're so snotty, they can't suck, swallow, and breathe, especially if they're babies. So smaller volume, more frequent.
Okay.
Oxygen is given in these kiddos if they're dyspneic, so they're having difficulty breathing, or tachypnic. Some medications are given for CHF kids, so like they might have a Lasix or something like that. It may also have DIG. It just kind of depends on the defect, but obviously knowing a consistent weight and that's not changing a lot can kind of also guide you on if they're taking their medications appropriately.
Okay.
Accurate INOs and daily weights are crucial in CHF kids. Because like we said, early signs of CHF in infants and also children is weight gain. Okay.
Yep.
Okay. Rheumatic fever. So this is an autoimmune disease that's caused from untreated group A beta hemolytic strep. Okay. So rheumatic fever becomes a systemic disease. Okay. So it's affecting multiple body systems. It affects the joints. It can affect the central nervous system, skin. So they're going to have a rash, subcutaneous tissues, swelling, redness, warmth, and then eventually potentially the heart as well. Penicillin is given to treat the strep first, and then they're going to be on a preventative. And minimum of 5 years. Okay. Now it says chemoprophylaxis monthly, so it depends on if they're doing oral or if they're doing an injectable. If it's bicillin, which is the injectable penicillin, they can do that once a month.
Okay.
But if it's oral, they'll have to take it every single day, twice a day. Okay. The preferred version, though, is to do the injection. Just because you don't have to worry about them not taking it routinely.
Right. Okay.
But if there's absolutely refusal for that, then you can do oral medications. Rest, relief of pain or fever, so anti-inflammatories, so your NSAIDs. If there's cardiac involvement from rheumatic fever, then some of these kids may be put on aspirin, okay, or steroids, okay. Eventually, if their cardiac involvement isn't addressed, then they can have cardiac failure.
Okay.
From strep. Okay.
That's crazy. Yeah.
Yep. That's why you never want to miss strep.
Yeah.
It's better to test over test.
Yeah.
Okay. Hypertension. So high blood pressure. Obviously, dietary changes, lifestyle changes are the things that are going to be suggested for kids. Now, if dietary changes and lifestyle changes are implemented and there's no improvement and there's still struggles, then cardiologists may look at putting them on blood pressure medications.
Okay.
So DASH diet, which I know you learned about that with your adult stuff.
Yes.
High cholesterol or hyperlipidemia is excessive lipids or fat-like substances in the blood. Okay. So there's LDL, which is low density lipoproteins. This is a low amount of triglycerides,
Okay.
high cholesterol, and some protein. Okay. And then there's HDL, which is a low amount of triglycerides, little cholesterol, and high proteins. Okay. So knowing kind of the difference between those two. So the HDLs carry the cholesterol to the liver to get rid of it. The LDL carries the cholesterol to the cells, which then that helps with cellular metabolism and steroid production. Okay. All right. Blood disorders. Any other questions about cardiac stuff? Not common that you see kids end up on statins or cholesterol meds.
Okay.
Once again, usually lifestyle change things first.
Okay.
Okay, blood disorders, chapter 27. So anemia. Most common blood disorder in childhood is anemia. Different forms of anemia. Okay. So decreased red blood cells or a decreased concentration of the red blood cells or both. That's kind of how you classify your anemias. Can be something that's acquired. So you have poor nutrition of iron rich foods. So we're going to acquire then an iron deficiency because we're not getting those foods. If it's inherited, then it's going to be something more like beta thalassemia or something where it's a genetic kind of cause.
Okay.
Right?
Mm-hmm.
Hyper or hypoproliferation can also play into anemia. Okay. So if there's a lot of red blood cells getting broken down, that's hyperproliferation. So then that's going to lead to anemia because there's a lot of blood cell destruction, red blood cell destruction. Okay.
Mm-hmm.
All right. Iron deficiency anemia, like I said, that was the most common nutritional deficiency in the US. Peaks between the ages of 9 and 24 months when we're no longer on infant formulas. Okay. And then during adolescence because of the rapid growth that occurs. Cow's milk worsens iron deficiency because it blocks the absorption of iron in the gut. So if kids are drinking tons of milk, they can cause themselves to be iron deficient. Iron should be given between meals, but with vitamin C. Okay.
Mm-hmm. And with the straw, if it's liquid or something.
The vitamin C with the straw?
No, the iron.
The iron, well, you can do like a dropper.
Okay.
It doesn't necessarily have to be a straw.
Okay.
But yeah, liquid. Is probably the most common form. Iron-rich foods, obviously red meats, liver, green leafy veggies. Okay. Hemophilia is a form of anemia. It's a hereditary blood disorder. So this is something that is acquired, or is congenital, right? We're born with it. Our blood does not clot appropriately with hemophilia. Hyperlipidemia, we already talked about, so I'm going to skip that one. Sickle cell anemia is also a hereditary blood disorder. So this has to come from both parents, right? That gene. Crisis happens when those sickled red blood cells accumulate and a clot forms, and then the oxygenation and that blood flow to that area where that clot is gets blocked essentially, right? Because it's clotted off. Treatment wise, oxygenating them if needed, hydration, and pain management. Okay. Erythropoietin, that increases the fetal hemoglobin. And the issue with the sickle cell is with adult hemoglobin. Okay. So if you give erythropoietin and that increases the fetal hemoglobin, potentially it can reduce the risk of crises. Okay.
Okay.
And the erythropoietin also helps to regulate red blood cell production in the kidneys. Okay.
Okay.
Thalassemia, it's a hereditary blood disorder. The body cannot produce enough adult hemoglobin. Okay. Thalassemia major or Cooley's anemia is probably the most common. It's also the most severe. So you'll see kids with Cooley's anemia, they're going to be jaundice. They're going to have that yellow color because their liver's involved in being affected. And then they're going to have cardiac failure because they're going to have significant anemia.
Okay.
Thalassemia minor or beta thalassemia trait. So that means that they only have one of the affected genes from one parent.
Okay. And it's mild.
It's going to be mild.
Okay.
And remember, thalassemia, the red blood cell is kind of more rectangular kind of shape versus circular.
Okay.
Also more common in Mediterranean population.
Okay.
Okay, leukemia. So education wise for kids with leukemia and parents with leukemia, obviously they're going to be on immune suppressants in the form of chemotherapy and steroids. So no vaccines during those time frames, but they need their vaccines because obviously they're at risk for infections. So usually what I'll try to happen is if they haven't had any vaccines and they can have them, we give them quick before they start treatment.
Okay.
But if that can't happen and we can't wait a little bit, then it's done after they're through treatment. Okay.
Yep.
Oral hygiene really needs to be very good because they can get ulcerations in their mouth, which then can become infected. If the kids with leukemia or who are on chemotherapy have fevers, it's straight to the hospital. Okay.
Mm-hmm.
All right. GU and GI. So chapters 28 and 29. Dysphagia is difficulty swallowing. Okay. The most common toxic drug ingestion that's utilized is, whether it's purposefully or not purposefully, is Tylenol or acetaminophen. Okay. GI disorders, there's obviously an impaired functional integrity potentially that causes fluid and electrolyte imbalance. With GI losses, so if there's, remember our vomiting, our vomiting is going to cause us to become metabolic alkalosis, right?
Yeah.
And then diarrhea is going to do the opposite, metabolic acidosis.
Acidosis.
We're getting rid of all that acid.
Okay.
Okay. With GI orders, most commonly, water intake, hydration, that sort of thing. Okay, pyloric stenosis. This is projectile vomiting. So like from here and hit the wall across the room vomiting. Okay, not just like a little bit of spit up. Okay, these babies need surgery. Okay.
Yep.
Beckles diverticulum is an outpouching or a bulge in the lower part of the small intestines. So surgery is done to remove that diverticulum and then any damage surrounding of the small intestines. Okay. Appendicitis is common in pediatric patients. Obviously, if they rupture, that's increased risk for peritonitis. So infection within the peritoneum, so within the abdomen. So that then requires an emergent appendectomy.
Okay.
And then they have to go in and kind of clean out all of the infection and an NG tube to get rid of all the infection. Okay. Suggestive findings of appendicitis is right lower quadrant pain. They're going to guard. They're not going to want you to touch their belly at all. They'll have worsening tenderness with letting go in that area of McBurney's point.
Yeah, the rebound tenderness. Yeah.
Yes.
Okay.
Yes. So
Mhm.
you push in and it's not so bad, but you let go and it's like terrible.
Yeah.
And McBurney's point is about halfway the distance between the right lower quadrant and your belly button. Halfway in there.
Halfway.
You're going to point. Okay. Your CRP is going to be elevated because that's suggestive of inflammation. You're going to have high white blood cells because you have an infection and that appendix is irritated. Your UA is going to probably be abnormal. You're going to have some protein or some ketones on your UA. You may need a stool culture, for GI disorders, figuring out what GI bug you have. Belly x-ray, CT, or ultrasound. So those are kind of all diagnostics testing things that go along with GI disorders.
Okay.
Post-op for appendicitis, vitals routinely, lab work to make sure that their white count and CRP and things are improving, pain control, and then slowly advancing their diet as tolerated.
You just mean from clear to
Yep.
like the stages. Okay.
Yep.
Okay.
Yep. Clear and then full liquid and then
Soft. Okay.
Yep. They may not go from full liquid to soft, but they might go like, more bland first and then normal.
Okay.
Yep. Hirschsprung's disease. So this is a congenital anomaly where the nerves within the intestine are not fully functional. So they don't get those signs that they need to have that stool. So that motility of the intestines is inadequate. Okay.
Okay.
So they will take out that A ganglionic, so the portion of the colon that does not have those nerve innervations, so that does not have those ganglion nerves sensations. They'll take that part out, and they may need a colonoscopy in place for bowel rest and then reverse it.
Okay. How long does it usually take to get the reversal?
Depends.
Okay.
Yeah, it just depends. Because some of them, if they're older, like say for some reason they didn't discover that they had Hirschsprung's for, a few months, they might just do the whole repair. They might not mess around with doing a colonoscopy or a colostomy bag.
Okay.
But yeah, it just kind of depends. If they're doing the intervention fairly early when the kiddo's young, then a lot of times they do the colostomy bag, and then they wait a few months until the kiddo's a little bit older. Usually they try to do the repair though before potty training age.
Right, you said that. Okay, thank you.
Yep. Gastroenteritis, so that's inflammation of the stomach and the intestinal lining, can happen from overfeeding. So non-infectious forms of diarrhea, overfeeding, too much sugar, not mixing the formula right, food intolerance, so not tolerating dairy or soy or something, and then ingesting high amounts of sorbitol. So if kids are getting a lot of juice, that's one of the most common causes of non-infectious diarrhea.
Okay.
Okay. Making sure you're keeping an eye on their admission rate and their current weight if they're hospitalized for dehydration.
Yeah. Okay.
Okay. Celiac disease. So this is an autoimmune disease in which the immune system overreacts to gluten. Okay. And that leads to malabsorption in the intestines. Okay. So diet should obviously be gluten-free. Okay. Hernias, incarceration of a hernia means that it doesn't reduce back into its normal place. Okay. Strangulation is when it doesn't reduce and then the blood supply becomes compromised. So incarcerated or strangulated hernias are right away to surgery.
Okay.
Okay. If belly, so abdominal hernias or ventral hernias are happening and they can reduce, so they can push back in and not have any issues, and they're not strangulated and they're not having any symptoms, then they kind of keep an eye on until they're a little bit older.
Okay.
Because a lot of times those abdominal muscles will fuse as the kiddo gets closer to 2, 3, 4, and then that hernia goes away. Glomerular nephritis, we've talked about quite a few times now. Some signs can be periorbital edema, so edema, swelling around the eye, pale, and anemia. And then that's obviously going to start after strep.
Yes.
Chronic constipation, diet changes are the best, most effective way. Dairy is going to be your most common issue for constipation. So stopping dairy and cutting or adding more raw fruits and veggies that are high in fiber. Okay, GU. UTIs.
Oh, you know what? It's almost one. I think you have to go at one.
It's okay. We can
Oh,
do
okay.
another couple pages.
Okay.
So UTIs, they're more common in girls just because we have a shorter urethra and our urethral opening is right next to our anal area, right? So we're more at risk for getting bacteria in there. Making sure that girls are wearing cotton underwear, that can help prevent UTIs. And then also offering them to go to the bathroom and make sure that they're staying hydrated.
Yep. Okay.
Hypospadias is the opening on the underside, okay, of the penis.
Yes.
And epispadias is the top side, okay.
Mm-hmm.
Cryptorchidism is when that testicle, one or both, do not descend into the scrotal sac like they should. Okay. And remember I said if kids, boys have cryptorchidism when they're young, they're more at risk for testicular cancer down the road. Okay, skin, impetigo, so that's staph or strep bacteria that causes those bullous or non-bullous lesions. Okay, so they'll need an antibiotic that covers both staph and strep, either oral or topical.
Mm-hmm.
Okay, ringworm, fungal, so they need an antifungal, whether that's oral or topical. Head lice, treat their head lice. Eczema is inflammation, typically genetic inflammation, that causes hypersensitivity in the skin. Can be from allergies or a variety of different things. So kind of figuring out the underlying cause and treating that.
Okay.
Burns is the #1 cause of death in young kiddos. So 1 to 4 years of age, right? Because of the age of curiosity. The rule of 9, remember Tequila brought that up today. So
yes,
sure you know that chart. Wound care, rehydration, making sure that they're eating plenty to heal their burns. Child abuse kind of things too. Be thinking about that.
Okay. So they just need a lot of hydration, a lot of protein for the healing process.
Fats.
Proteins. Okay. Okay.
Fats and proteins. Yep.
Okay.
And overall calorie intake too.
Oh yeah, you said 3 times the amount of what they normally need.
That's about. So that's not like direct from your book.
Okay.
But usually, typical kids maybe are like 15 to 2,000 calories a day. They might be up to 4,000, 5,000 calories a day when they're, depending on how significant their burns are.
Okay.
Okay. Acne, make sure you're keeping track of what to do for acne. Okay. And stressing to those teenagers to do their medications as they're prescribed. Otherwise, their acne is going to continue to be problematic to them.
Yep. Now, if it's really bad, like cystic acne or something, they might go on like a tetracycline or something like that. But that's pretty.
Yep.
Pretty must be severe for that.
Yep.
Okay.
But they're also still going to be doing topical treatments too.
Oh, okay.
Yep.
Okay.
Yep. Know your thyroid dysfunction. Remember diabetes mellitus versus diabetes insipidus.
Oh, yes.
Okay. Diabetes, let's see. Insipidus is going to be your excessive feeling like they have to drink and excrete all of that out. Okay. Because they're decreased vasopressin, so low antidiuretic hormone.
Yep.
Okay. Cushing syndrome is overproduction of cortisol. We didn't talk about that in our slide. So they're going to have overproduction of that stress hormone cortisol, which then increases the glucose production as well. And then that causes that moon face.
Yes.
So when people are on steroids for a really, really long time, they get that moon face. That's a condition. Like steroid usage for a long period of time or abrupt stop of steroids can cause Cushing's syndrome to happen.
Okay.
Okay. Okay. And then go through the types of immunity.
Oh, okay.
Okay. So this is chapter 32 that we didn't get to in class, but natural immunity is something that you're born with, right?
Right.
Acquired is you're not born with it, but you get it from a vaccine or from having the disease. Active immunity is when you're producing your own immunity. So you get that disease and your immune system starts working to fight that infection by making antibodies. Passive immunity is providing the antibodies to that person. So passive immunity, a form of that would be getting those, monoclonal antibodies against COVID.
Oh,
We heard about that.
Yeah.
So that's a form of passive immunity. So giving you antibodies to try and fight off the infection, but it's not going to last you like if you've had the
like the active immunity, right?
Yes.
Okay.
Yes, antibody production yourself.
Okay.
Yep. And then know your dosage calculations. Okay.
Yeah.
There's another video under exam 3 that goes through that. Okay.
Thank you so much.
Yeah, you're welcome. I hope
I
it was
really
helpful to
appreciate
you.
it. Yeah, I was just kind of confused on a couple of the stuff before that quiz, so it's now cleared up. So thank you very much.
Yeah, so just go back through your GI stuff, make sure you know that. But yeah, use your study guides from each week to help kind of guide your studying. If you see something on there and you're like, gosh, I don't remember reading about that, go back and read about it again.
Thank you so much. All right.
Yep.
You have a good day.
Later. Yep,
All right.
you too.
Bye-bye.
Bye.